Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. It is Tuesday, May 12th, 2020. This is episode 134. And today I'm going to bring you a mixed bag of new services that are now covered under the Waiver 1135 during the public health emergency and during the pandemic. We're going to talk about some modifier updates. It's a melting pot of information that I really believe you need. And you probably have not had time to catch up. You're reading on the hundreds of pages of materials you had just received, or you're waiting for Terry Tuesday and say, you know what, Terry will update us. So there's a lot of information out there. One of the gems that I found has regard to a specimen collection for COVID testing. And on one of the documents, it was found on page 192 at the bottom. Also, I attend the biweekly meetings, which is the CMS office hours calls, and listen to all the questions and responses from Medicare and CMS that they put out over the airwaves. Some make it to their FAQ sheets, some make it to their online blog posts, some doesn't. So I'll be able to speak to a lot of information as well. That is just, it's really a mixed bag. It's just some information that they put out there. They had some things on the call, and I want to make sure that you have it as well. Okay, so first, the Codecast is also brought to you today by Keck Medicine of USC, the Keck Effect. So let's get to these updates, and there are quite a few. So the first thing are a couple of modifiers that I want to talk about. So the Bush era modifier has been revived. There's been a couple of them to let contractors know, those are the payers, when you've posted a claim for a service that is only allowed now because of waivers employed for the COVID-19 public health emergency. So it's a CR modifier, and it's called catastrophic disaster related. First appeared in 2005 when we had Hurricane Katrina. Can you believe that's been 15 years ago? At the time, CMS also issued a modifier DR, and that was facility version of that for disaster-related services, and that was back again in 2005. So they revised the modifier CR, actually both modifiers, and they can be used during the PHE. Now, these are for, and I'll quote from what they said on April 10th on the guidance. It says, for which Medicare payment is based on a formal waiver, including but not limited to Section 1135 or Section 1812F of the Act. And so you also find this in a MedLearn Matters SE 211 education piece. The formal waivers are also defined in Chapter 38 of the Medicare Claims Processing Manual, and it says any waiver of a program requirement that otherwise would apply by statute or regulation, and it says including the 1135 waivers. So they call them blanket waivers as well. You might have seen that. There was an emergency posting of that on the 30th of April, which is our most recent, and then today we had one of our office hours calls. But just know this is not for telemedicine. The CR modifier is for anything that is provided under the waivers that isn't for telemedicine. So that would be a little bit different, because if we're dealing with synchronous telehealth that we talked about before under real-time interactive audio and video telecommunication, that's a 95 modifier. Remember, you don't need the 95 when you're just talking about phone calls or virtual check-ins or the digital services through the portal. Those are all telemedicine. Even though it's listed under the telehealth, you didn't want to add a modifier that says it's under video, because what it is itself is paid under the fee schedule at this point during the public health emergency. Office visits have to be tracked, so you can't submit an office visit without a 95 modifier if it's through telehealth, because that would be a fraudulent claim. So make sure you have two modifiers so far. So that's CR, and that is for the catastrophe disaster related, and this is for Part B services. 95 is for the synchronous telemedicine service. And then we also have a CS modifier. And this is to be used on applicable claim lines to identify the service as subject to the cost-sharing waiver for the COVID-19 testing and related services. So there was an edition of April 7th, which was on a MedLearn Matters article published as well, that discussed the COVID testing modifier, which would be the CS. Because remember, you don't have to charge your patient out of pocket. And when you put the CS on, it's different than the information that was given before that said you have the option to charge your patient a share of cost or not to charge them a share of cost. This is for patients that have tested positive for COVID or are being tested for COVID-19, and all of their out-of-pocket is being waived, which means that the provider who's doing the testing is actually going to get 100% of allowable. And I might have mentioned this last week. I've also done 3 different telehealth webinars in the last week. So if I've mentioned it before, then just know that you're getting the update again, because sometimes some of this is just flowing all together for me. It's kind of crazy. Now, and speaking of the COVID testing, something that came up on the IFC. Now, remember the IFC, Interim Final Rule with Comment Period. That's why it's not called the IFR. They put in that C for comment period. On page 192 at the bottom. This is about specimen collection when testing for COVID. So the codes are their HCPCS codes, G2023 and G2024. Now, you can use those codes. They're worth anywhere from $3 to $7, I think. Or you can use the 99211 as long as it is an appropriate healthcare practitioner or provider and that can use any kind of E&M service for your code specimen collection. And remember, because that is for that COVID-19 to testing, then you want to make sure that you have that CS modifier on it as well to get 100%. Now, a question came up on the office hours call regarding the code specimen collection, and the gal had said, what about C9803? Remember, anything that has a C in front of it, that is under the OPPS, so that's under the outpatient payment perspective system. So that doesn't apply to Part B or physicians. That is for hospitals and for outpatient centers. So no, if you see a C, that's not going to be for a physician's office. You have to go back either to the level 1 established patient office visit or the HCPCS G codes. So a question came up today regarding testing, and I wanted to address it because it has to do with COVID and basically getting specimen collections. It says a patient sees the physician in the office with signs and symptoms of fever, cough, and shortness of breath. The final diagnosis by the physician is documented as a viral illness, and he assigns the code B as in boy 34.9, viral infection unspecified. He didn't mention any screening or contact for COVID. Can they still put the CS modifier on that? The answer is no. The doctor would have had to say that there was an exposure, there was an indirect exposure, there was a potential testing, even a negative test, you could still put it on there because you were trying to figure out if the patient had it. But if the physician doesn't put anything that relates to COVID on there, not even testing for it, you can't waive the out-of-pocket. So there was a lot of changes on this, and if there's no mention of COVID and no COVID testing done, that's just considered a normal outpatient sick visit, and do not add that CS modifier. And so that's really important because, and I'm not actually sure why a doctor wouldn't do that, but that is a question that came in today because those are clear signs and symptoms that there's a potential COVID patient there. Another question came up as far as what do you use for testing? So my laboratory uses a CDC test kit. What should we use to bill Medicare for testing for COVID? The appropriate code to use would be the new HCPCS code U0001, and that's the CDC COVID-19 real-time testing diagnostic panel. But if you don't use that testing kit, what code would we use to bill Medicare? If your laboratory uses the method specified by the code 87635, then that's going to be the code you're going to use. If they have a test that's not described by the 87635, then you may want to look to the U0002 code. So there's a lot of information when it comes to testing that you want to be clear of. Also, something came up as far as, can you tell us now some of the new providers that are allowed to bill for telehealth? Well, we now have speech pathologists, we have clinical social workers, we have occupational therapists, physical therapists, but remember, they're not allowed to bill office visits. They can bill their therapy codes that they used to only be able to bill in person under the supervision of a physician, but now they can bill those. And they can bill the non-physician phone calls if they have a time-based code. So this is not an MA or an RN or an LVN or LPN. These are basically specific practitioners that have now been added to the telehealth rules. So this is really important to understand that. Another thing came up as far as a provider that is providing services from their home. So if a doctor is at home and not in their office and sees a patient via telehealth, would the place of service, what would that be? Well, that would be 11, because they're saying Medicare has said that under the waiver, the doctor doesn't have to put on the enrollment form that they have a separate office in their home. If they're going to continue with telemedicine after the health emergency is lifted, and obviously it would be on a limited basis because Medicare is going to roll back some of the changes. But if they're going to do that, they have to put it on their enrollment form. This is just waiving some flexibilities and having some flexibilities, I should say, waiving some regulations under the public health emergency. Another thing has come up as far as what about a retired physician or seeing patients out of state? Now, this is a big one. I have a client in Oregon and one in Arizona that was asking this. So a lot of times people were flocking to Arizona, because they are snowbirds. Well, what if your provider is seeing now that patient who used to live in Seattle? What do we do? Because they still want to see that provider. If it's psychiatric therapy, if it is their cardiologist and they want to do a telehealth service, well, you first have to check with your malpractice carrier. Find out if you're still covered under malpractice when you're seeing a patient, not only under telehealth, but also out of state. You may not be covered. Second, if you are covered, then Medicare has relaxed the rules on that, and you can see a patient under the telehealth out of state as long as your malpractice also allows you to do it as well. So on the 5.1 FAQ sheet, I thought this was interesting because it was almost like CMS was a little angry with the rural health clinics, the way they put it in there in federally qualified healthcare centers. It said, so has CMS implemented any changes to help RHCs and FQHCs respond to the serious public health threats posed by the spread of the novel coronavirus? Yes, CMS has removed some of the regulatory requirements and added additional flexibilities to assist these entities in furnishing the services. So the first one was now they're going to allow patients that have access to their patient portal, the digital evaluation and management services, those can be billed. Those were usually under an umbrella because remember, rural health clinics have basically one code that they put on their cost sheet. And then they also said, when do these changes go into effect? This is the answer I thought was kind of rude, but these changes are in effect for the duration of the COVID-19 PHE and are not permanent. I mean, they were clear. These are not permanent. And then somebody else asked in the next question, are these changes permanent? These changes are not permanent. So I had to laugh at that only because you needed to wait a second before you knew what was appropriate there. And then they talk about one thing that's interesting is that it says, what are the specifics for these services? And they said these codes have been added. They talk about 99421 to 423, and it talks about some of the cumulative days. There's some globals around there. And then somebody else asked, well, what is an online portal? Well, that is a patient portal. That's a secure online website that gives patients 24-hour access to their personal health information, what you allow them to have from anywhere with internet connection by using a secure username and password. You might want to put some, I wouldn't say rules on that, but maybe some restrictions just to make sure that your patients don't kind of lose their mind with that and keep just asking you every possible question. It's just supposed to be for COVID-related questions, or if there is a patient that has a question with regard to some tests that they're looking at within the portal. A question came up on home health services, and I was trying to wrap my head around it, and hospice services via telehealth, where if you're already providing that service for a patient that the doctor's either at home or in the office and doesn't go to the patient's home, but does a telehealth through the patient's home and the patient's at home, what's the difference between home health and then an actual visit that you're now allowed to charge the same way? You'd have a different place of service if you're a home health physician, but what I found out actually on the FAQ is on one of the last pages. And what it does is it talks about this and basically said, it's on page 50 of the new 5.1 update. It says home health agency physicians, home health hospice agency physicians that are providing these services via telehealth, then they're going to bill with the place of service home health or hospice. If it is a physician who normally provides service in their office to patients and does not provide provide home health, then they're going to use the office place of service. So that was a good clarification because it didn't make sense to me on how that would work. So just know it's if you're an agency physician through home health or hospice, then you keep with the place of service that works for you. I know there's a difference in payment, but we have to make sure that we are on the up and up and not trying to get around anything. I heard today something where somebody was trying to file for unemployment that was, or was asked to file for unemployment, I should say, that was a housewife. Well, you don't qualify for unemployment. So I appreciated that person telling me that, yeah, she's like, I'm not doing that. That's ridiculous. So you have to be careful because there's a lot of things going on out there that you got to be careful of. Okay, so let's get to our coding question. And yay, I have an actual coding question. It has nothing to do with this. Cardiology. So a cardiologist converted a single chamber pacemaker to a dual chamber pacemaker system by adding an electrode to the right atrium. The cardiologist also replaced the generator. Which CPT code should I report for this procedure? Okay, so thank you, Sharon in Ohio. You would report the 33214 code. And what that is that's the upgrade of an implanted pacemaker system, conversion of a single chamber system to dual chamber system. It includes the removal of a previously placed pulse generator, so the battery, and testing of the existing lead, insertion of the new lead, and insertion of the new pulse generator, because now you have to have a separate area for the coil to wrap around. Do not try and code for the insertion of one electrode or an extra electrode or a single electrode or the removal and replacement of a pulse generator with the codes 33216, 217, or 33227 to 229. The code 33214 includes the upgrade and adding all of those things. So make sure you're using the inclusive code and not coding piecemeal on this because that would be inappropriate. One other question I have, what are the rules for coding an old MI? And that would be a myocardial infarction. So you have a few rules to follow for old MIs according to the ICD-10 official guidelines. If the myocardial infarction, which is a heart attack, is equal or less than 4 weeks, then you would report a code from the category I-21, acute MI, through category I-22 for possible subsequent. After that 4-week period time frame, and if the patient is still receiving care related to the myocardial infarction, then you would instead report the code for aftercare code or old MI, which is I-25.2. So hopefully you found that helpful. Okay, your coding question was brought to you today by Advanced MD, cloud software for independent medical practices that delivers industry-leading patient outcomes and financial performances. Also a leader in telemedicine modules, advancedmd.com. So my ending today comes from some of the things that I'm doing. I was telling you last week with regard to trying to fill some time when I'm not at my office and I'm at home, and obviously we can't go to restaurants or see our friends right now or anything. Even though we are in California, we are actually in phase 2 out of phase 4. So I'm excited about that. But we've been doing these Zoom happy hours with friends and also wineries from Napa that I belong to, and also wineries up in Oregon that my brothers belong to. So are they pass or fail? Well, I was on one last night and it was a winery up in Oregon, and I will not mention their name because I think this was a fail, which was only amusing to me only because then an email came through that my brother forwarded to me where one of the sommeliers there, one of the wine guys there that talks about the wine that I've met before, Chuck, he basically was funny. Charles, he's like, what was that? He goes, that wasn't fun. So the gal that was running it after she opened up Zoom and then opened up Facebook Live, she put up a PowerPoint. And then she started asking people for their story and that were also presenting with her. And it was almost like a class. Yeah, I don't want a class at 5:30 at night with a glass of wine unless somebody tells me I'm taking a class. But I deal with PowerPoints all day long, so keep the PowerPoints out. But then one of my favorite wineries in Napa, Alpha Omega Wineries, they had 3 of their sommeliers, and the guys were out there with the water feature in the background. They have a beautiful outdoor space, and they were practicing social distancing, probably more like 4 feet than 6 feet. But they all had a glass of wine, and they were sitting in these big comfy chairs that I know we go to when I'm there, and just talking about wine. And you could chat in something and put in there. You could hear them, but they couldn't hear us. You could type in something on the chat on Instagram Live, and that was fun. I would have preferred being able to talk to them, but it was kind of great just to hear them talk and hear about the wine, and that was a pass. So there's a way to do this, and there's ways not to do it. I actually have a Zoom happy hour with 4 of my friends this week, and I'm excited about that, and a Zoom lunch actually with a friend of mine this Saturday. So always exciting when you can get people to say, you know what, we miss you and we want to see you, and what are you up for? So you know what, we have to find a way to connect in this time, and hopefully soon we'll get back to being able to see each other live. So everyone, make it a great week and just a great day, and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.